It is universally acknowledged that respiratory diseases, acute respiratory infections, influenza-like illnesses, and influenza itself present one of the most significant, if not even the most significant, of all communicable diseases. That is due to their high incidence, due to significant mortality, but also due to direct and indirect economical costs and financial consequences. In local context and in terms of my home country, although we are lacking disease burden data, acute respiratory infections and influenza-like illnesses are indeed the single most important group of communicable diseases, with incidence of ILI ranging more than 1,200 on 100,000 population, which is putting them on the true top of the communicable diseases in our country. Therefore, various and numerous measures have been developed and implemented throughout the world aiming at preventing, controlling, and mitigating effects of acute respiratory infections. Most of those measures have been grouped in two big groups, one of them based mainly on pharmaceutical things such as chemioprophylaxis and vaccines or immunobiologicals, while the other group of measures is solely based on social distancing. In other words, trying to lower the contacts between infected and susceptible ones. In our focus was one of those measures, as we in this study tried to assess the impact of scheduled winter school break closures on the incidence of ILI infections in Montenegro during these previously mentioned 5 years. In completing this objective, we have used National Acute Respiratory Diseases and ILI surveillance system, which is fairly new, automated, real-time surveillance system that is electronic and with full 100% coverage of the whole primary healthcare level. As denominator, we have used National Statistics Office data, which is, when having in mind the population of Montenegro is a little more than 600,000, was quite easy to obtain. These data were collected automatically from the primary healthcare level, and the only thing that our colleagues there had to do was to follow the EU modified case definition of ILI, and then according to those fulfilling the case definition, to code them using the ICD 10th revision disease classification. Codes used were J09, J10, and J11. All the data gathered were analyzed on daily levels, but during the analytical part of our study, we have calculated weekly ILI incidence rates among 6 different age groups that are commonly used when reporting to WHO regional office in terms of ILI incidence and absolute numbers. And also, when trying to quantify the true effect of school closures, what we have done, we have calculated incidence rate ratio among 2 most important groups, those who were directly involved and exposed to the school closing, younger than 20 years of age, and other who weren't directly exposed. All the calculations for incident rate ratios have been done in 3 times period, that is during, but also before and after the school breaks. When we get to the results that we have obtained in this study, it is very important to note that changes and differences among ILI incidences across the season was something that stabbed our eyes. These differences varied between season, each and every season, but what also varied was the time of reaching the peak of the epidemics and also the height of the curve, that is the maximum number and the maximal incidence. Same thing was observed throughout the whole 6 age groups that we used in our study. But what I would like to stress here is that the severity of the disease and the numbers, the highest numbers and the highest age-specific incidence was recorded in those, the most young ones. And therefore, we have only focused on following 2 age groups, as I already mentioned, while doing the calculations. In red, we have shown age-specific incidence for those younger than 20 years of age, and in blue are shown the ones older than 20 years. Of course, in all three last slides, school closures have been marked in orange, and I would like to point out that each and every year they were scheduled in the very same period of the calendar, very same period of the year, and that period didn't match the dynamics of the disease. If we only focus on two most important age groups and on one season, that is season 2012 and 2014, what we can see is that disease dynamics in younger than 20 years of age was preceding the disease in the elders, and that during the school breaks, what first happened was obtaining a small plateau, then decline in the incidence, while upon the school reopening, incidence like a flame went up explosively, reaching the peak a couple of weeks following the school reopening. The same thing, but in much lower amplitude and with significant delay, was observed among the elders, which might indicate that disease is primarily occurring among the youngers, and that the youngers are taking the disease back at home to their elders, to their older siblings, mothers, fathers, and grandfathers. As already mentioned, we haven't focused only on the period of school closures. What we have done, we have used the same length of time preceding the school closure, and also we have focused on the same amount of time, the same length of time following the school closures. In our analysis, we have excluded two very important periods of time. That is the first week of the school closures and the first week following the school reopening, because the incidences in those 2 weeks are actually reflecting the social mixing patterns that occurred in times imminently preceding them. Speaking about the results, in terms of incidence rate ratios that we have calculated, the most important thing is that in 3 out of 5 of the observed season, incident rate ratios lowered during the school breaks in comparing it with the period before the school breaks, which actually means that the risk of contracting the disease among the younger was lower during the school breaks. Even more important was the finding that occurred after the school reopening, as in all of the 5 seasons we have noted rise in incidence rate ratio, and this rise was statistically significant in 4 out of the 5 seasons, which actually means that the reopening of the school indeed has bigger epidemiological significance than the closing itself. In terms of what we have learned from this study showed great incidence variations according to the age and the season, and it just stressed the unpredictability of ILI epidemics and unpredictability of any respiratory diseases epidemics. Results that we came up with are in accordance with other available scientific evidence, and they indeed do have an additional significance to us, as this was the first study of this kind in Montenegro that provided evidence that we possibly can use in developing strategic documents. We did try to exclude as many factors as possible and to have as many limitations as possible, but unfortunately not all limitations could be excluded. Therefore, we believe that the limitations and the weaknesses of our study are exclusion of other control and prevention measures, mainly immunization measures across the population. Then we didn't include and we didn't obtain, and that's the hardest thing to obtain, data on social mixing patterns of people in all the age groups. And finally, we have excluded other surveillance system, namely Sari surveillance system of Montenegro. When we get to the conclusion, scheduled winter school breaks, as I already said, occurred in different phases of the outbreak, and that is probably the single most important thing influencing or affecting the school closure itself, because if timed properly and in early phases of disease spread, closing of schools may be useful. The usefulness of this measure is emphasized if used along with other mitigation and prevention and control measures, and it is not to be used as a standalone measure. And if lasting long enough, it can indeed provide useful for mitigating and controlling the disease. What was, as you have seen, also very important is that the reopening of school favored increase in ILI incidence, and I stress again, in all of the observed years. Finally, what we have came up with this study may be taken into consideration when developing preparedness plans, and this measure can be thought about as proactive, meaning to use it as prevention measure, to use it as opportunistic, as it is in Montenegro, because the school breaks are scheduled fixedly during the epidemics period, and reactive as our response to the epidemics. Last and not the least are acknowledgements, and I would like to thank to my professors, Professor Laušević and Professor Tepačević, for guiding me through this process, and also to my MediPIET scientific officer. Thank you.
Senad, thank you very much for very interesting presentations, and thank you for bringing this at the panel, this controversial discussion. Is it effective or not effective to close the school during the influenza season period? I will open the session for questions and discussions. Sylvia, please.
No, thank you very much. Those are social distance measures. But I just want to ask, have you tried to see beyond the 20 years old, or you just took the until 20-year-old? The first question. And the second one, did you see a difference among different age groups in the influenza, in the early rates compared to each other? So until 20 years old, did you see the difference during school breaks?
First of all, thank you for your question. What we've done analysis for each and every of the age groups, and we came up with something that looked like salad of data. And it was really hard to distinguish what is important and what is not important. Therefore, we have made only 2 age groups, as school closures are affecting all those younger than 20 years, and those are children in kindergartens, children in primary, and children in secondary schools. Older than 20 years are workers, students, adults, and therefore we have made a separate age group for them, and that's why we've compared them. When it gets to the age groups themselves, I believe that the answer to that part of the question lies in this graph. And you indeed can see that there are differences among different ages across the seasons. And that only stresses what really is important about influenza and influenza-like illnesses. And that's the unpredictability of disease dynamics. I mean, we didn't focus on specific type of viruses circulating. We were just following ILIs. And it really showed big differences across the seasons and across the ages. So indeed, there is a pattern that is different among the children and adults of different ages.
Okay, thank you. Another question? So, if no, I will have just a small comment. As we mentioned, that the discussions related to implement social distancing strategy, like closure strategy, closure the school is in process, and professionals, epidemiologists, divided into groups. One of these groups reiterate that this measure is effective and should be implemented during the peak of the influenza season. Other group reiterate that this is not effective measure and we should not close the school. But what is important to mention here, the decision should be take into consideration some issues. First of all, the most important is to take into account the severity of the diseases during the season, to take into account the type of viruses what is circulated, and what is the transmissibility of this virus, what is the speed of the spread of the disease, including in this group of children, and of course to take into account the impact, including social impact and economic impact. Saying this, I hope the decision makers from the country we will have, using all available data, including these three main things what should be taken into account, will approve appropriate decision in order to decrease the spread of the influenza during the season. Thank you very much.
If I may answer, I completely agree with you. Indeed, it seems that timeliness and specific time when schools are closed has the greatest influence on the outcome of the measure itself. It can be seen here in 2010. Schools were closed when the incidence was really high. It did give us plateau. It did buy us time to buy a vaccine, get a vaccine, or something like that. In terms of pandemics, that's very important when you don't have a specific measure. Then you may think about closing the schools and buy time while trying to get specific protective and preventive measures. I do agree with you that the cost effectiveness of this measure is extremely important, especially in developed and Western countries. We have something that is called granny service. It's grandmas and grandpas taking care of the children who are away from schools. And that's the pattern that is not quite common to developed countries. And third, and very important, is the true social mixing pattern. If we close schools and then let our children go and hang out in shopping malls, playgrounds, video game sites, I don't know, arcades, then we've done nothing. Thank you.
Any other questions, comments? No? Thank you very much.